Welcome to the March issue of eVision newsletter for the Pan American Association of Ophthalmology. It's our pleasure to speak with Dr. Carol Shields, currently the co-director of the Oncology Service at Wills Eye Hospital and professor of ophthalmology at Thomas Jefferson University in Philadelphia. Dr. Shields, you are going to be the lecturer for the Gradle Lecture, one of the most important lectures at the Pan American, and you will be speaking August 11th of this year from 8:30 to 9. Could you please share with our audience the main points, the abstract of the Gradle Lecture on uveal melanoma?
Sure. Wow. It's really a great honor for me to win the award to deliver this lecture. You know, I've been a member of the Pan American Society for several decades now, never thinking that I would be asked to give one of these honorable lectures. So in the Harry S. Gradle, MD lecture, I'll be speaking on uveal melanoma, and I'll talk about a few things, some really practical things about how you can judge the risk of a melanoma metastasizing just by clinical features. And I'll talk about personalized prognosis, how we as ocular oncologists can look at a melanoma, sample the tumor, and look at the genetics, whether it's DNA or RNA, and give a real personalized prognosis to the patient, knowing what their risk is for metastatic disease. And then last, I'm going to finish off with some really exciting new information on new therapies for uveal melanoma. Most of us are aware of the older therapies of radiotherapy and enucleation, but we have some new up-and-coming therapies. So, you know, just in a nutshell, let me just get on with some of the highlights of what my talk will be. I'll start out by reminding all of the attendees who Harry Gradle was. You know, Harry Gradle was, he was born in Chicago of German-Irish parents. He served in the U.S. Army. He was one of the initial people to establish the Armed Forces Institute of Pathology. He won many honors, and he served as the president of the AAO and also the president of the PAAO. So he was really a man of great achievement. So in his honor, I'll start out by talking about uveal melanoma and how we can judge tumor risk by looking at tumor thickness. Every millimeter a melanoma gets thicker adds another 5% risk for metastatic disease at 10 years. And if we can catch melanoma when it's very small, like maybe under 2 millimeters, we may be able to save a life, because most tumors, if they're going to metastasize, are at least about 3 by 3 by 1.5 millimeters. So we like to catch melanoma when they're really tiny using risk factors. Next thing I'll focus on will be a little bit on the genetics of melanoma. And I actually just submitted for publication the paper, the Harry S. Gradle paper on personalized prognosis with uveal melanoma using cytogenetics. And just by looking at the genetics within a patient's tumor, we can get a feeling or scientific information on whether the tumor is at high or low risk for metastasis. And if it's at low risk, we don't give any additional therapy. But if it's at high risk, then we give the patient additional systemic therapy to help prevent metastatic disease. And the last thing I'm going to talk about is a little bit on some new therapies. There's a new therapy that's actually just FDA approved. It's called Aura Bioscience, Aura 011. And we are just treating this week our first patient with uveal melanoma using this new therapy. It involves nanoparticles that we inject into the eye. They are attached to the melanoma. They carry a little chromophore tail, and then we shine laser light on them, and it causes immediate necrosis of the tumor. So hopefully by the time in August that we have this meeting, I'll have some information on some of the preliminary observations with that new therapy. And also I just want to make a comment on some new systemic therapies. Patients with uveal melanoma, once they develop metastatic disease, they were at big risk for death, usually within 1 year. But now we have a whole group of patients who've been alive for 2, 3, 5 years on newer immune modulating therapies. so we can give a therapy that actually attacks the melanoma cells. It's not chemotherapy, it's immune modulating therapy. And I'll say a few words about that too. So there's a lot going on in the field of uveal melanoma. We're making improvements, we're catching tumors earlier, and now we have better local and better systemic therapies. I hope all of you can attend the lecture. I think it'll be very informative, and it's, all of us sharing our experience, making the world a better place.
Thank you so much, Dr. Shields. So much to look forward to in the greater lecture. Thank you.
Okay, thank you.